Hello everyone, welcome to Introduction to Dermoscopy course. My name is Dr. Kwesi Apia. I am a GP with extended role in dermatology. I work for Stella Healthcare, and I've also been working as a clinical assistant in dermatology at Broomfield, where I've been doing that for the past 4 years or so, where I've been doing general dermatology clinics and also 2-week weight clinics as an outpatient doctor. So this course is aimed to be for GPs, and it is for as a result of some pilot scheme from the Royal Free London, UCLH and London Collaborative Initiative, and where the idea is multi-year pilots to test whether dermoscopy can help GPs in North East London and West Essex to assess skin lesions. And the whole idea of this was meant for GPs to attend a half-day lunch event using a dermoscopy in their practice or practice networks, keeping a log of referrals made following a dermoscopy examination. And the aim of their collaborative initiative is for the GPs to be able to improve their confidence in assessing skin lesions, so that a higher proportion of melanomas and SCCs diagnosed via urgent referrals. They also will, like the proportion of urgent referrals, will have melanomas and SCCs, and invariably want to reduce a lower number of urgent referrals for common benign lesions, which dermoscopy can help identify, particularly in seborrheic keratosis and hemangiomas. So what we're going to do is go through some basic anatomy and histology of dermoscopy. What I've done in this videos is, instead of what we did in the live session where we did a two-hour presentation, and this video recording will be broken into 3 parts so that you can go through slowly to help you assimilate the information in this presentation. There is a lot to cover, therefore we'll not have enough time to do it and do it in chunks, get information in chunks and help you to assimilate it. And this recording really has kind of been helpful as a result of the feedback from the live version that we had from various participants, and that's why I decided to deliver the recording this way. So the first part in anatomy is, if we look at pigment network, this is the anatomy of the skin and histology of the skin. And the pigment network in dermoscopy in melanocytic lesions is due to an increased density of melanin pigment down the epidermal reti regions, forming the great cords of the network. So this is the epidermal reti regions where my arrow is pointing, and this is dermopapilla and the dermis. So usually with dermoscopy, you're looking up and down to the skin, and you're looking as far as structures in the dermis. You don't see anything in the subcutis or hypodermis, but really many in the papillary dermis, and also a bit of structures in the reticular dermis deeper down. But mainly you're looking at epidermal structures in terms of pigmentation of melanin in epidermis. And what you see in the network is because of this reti ridges, which are these holes that you see in the over the papillary dermis, as you can see here. So these, where I said, these relative low vertical densities seen the dermopapillary form the holes in the network, whereas the epidermal reti ridges form the grits. These are the grits in there. You can see the grits there, and the holes are filled with the reti ridges. Okay, so that's a bit of anatomy. So this is how we look at a schematic diagram is how it looks like of the skin. So these are the reti ridges, and then the dermopapillary is what you see there. So they become the holes. The papillary becomes the holes all throughout the skin. So using dermoscopy, the color of the skin depends upon two main pigments, which is melanin and hemoglobin. Melanin and hemoglobin. The latter, which is a hemoglobin, depends on the appearance of either red or blue, depending on either the blood is oxygenated and the depth of the vessels within the skin. And that's the thing you're looking for, is that the oxygenated blood, and the color will appear between red and blue. Melanin, on the other hand, is dark brown to black pigments in nature, and its colors, when visualizing dermoscopy, depend on its location in the skin. So one of the feedbacks I got from the live lesson was, how would dermoscopy look on pigmented skin? So we all have the same amount of melanocytes, whether it's skin type 1 or skin type 6. However, the melanosomes, which is the pigments carriers of melanin, is much more in darker skin type. So skin type 4, 5, 6 will have more melanosomes, but the same amount of melanocytes and surrounding keratinocytes on the skin. So these are the melanocytes, and these are melanosomes. These are the brown dots in the melanocytes, which carries the melanin. So we all have the same number of melanocytes, but in a dark skinned person, you have more melanosomes. Therefore, you can still appreciate lesions in Black and ethnic minority skin, or skin type 4, 5, 6, but you tend to have a darker background in general, because of the number of melanosomes. Obviously, the dermoscopy was developed in skin type 1, 2, mainly for distinguishing between pigmented lesions, and that's melanocytic lesions. However, as years gone by, it's evolved that it can be used in various other ways as well. So in the epidermis, melanin pigment can be found in melanocytes, as I said, with neighboring keratinocytes. So all these are the keratinocytes in there. This is the basal cells here, and this is one melanocyte here, and surrounding keratinocytes in the basal cells. And all these, as you come up in the upper layer of the epidermis until you get to the horny cell layer, these are all keratinocytes, and they are all joined by dendritic processes from the melanocytes, which make you appreciate the melanosomes more when you're looking through a dermoscopy. So in many pigmented lesions, majority of epidermal melanin may be found in the basal or suprabasal keratinocytes. So as I said, yes, this is the basal keratinocytes, and suprabasal keratinocytes are here. So this is kind of a histological picture, which shows a little bit of keratinocytes and melanocytes, and shows you that epidermis is composed mainly 95% of keratinocytes. Remember from the picture we saw, with 5% of melanocytes and a smaller number of Langerhans and Meckel cells for their defense mechanism. So going from here, from the base coming up, this is a basal layer of the epidermis, and this is the dermis. So in the basal layer, where the red arrow is pointing, is here, and you can see the melanocytes that are the darker cells. You can see them, and when you're coming up with B, we'll be getting mature keratinocytes, and then as you get up to C, you get a granular layer, and then the surface will be the superficial conified layer, or with coniocytes, which are dead keratinocytes. So The keratinocytes, as they progress upwards, they become dead and become conified and become scales or thickened, as you see. So you can see that the melanocytes along the base you have for each one melanocyte is connected to about 40 adjacent keratinocytes. So you have one melanocyte and you count another 40 adjacent keratinocytes, either just around the basal layer or even in the granular layer, as they attach themselves to them through their dendritic process that I showed you in a previous image. Okay, just a little bit background of that, but let's go straight to dermoscopy. So melanin depends on the layer of the skin of which melanin is located. So it may appear black when it's located on the stratum corneum. It may appear brown when located on the basal layer of the epidermis. It may appear gray when located on the papillary dermis. Blue when it's located on reticular dermis. So the deeper you go, it just appears blue. So this is really important in how you're observing lesions, particularly blue nevus, because it's melanin, will look deep because they are dermal nevus. So the observation of colors depends upon the density of the melanin. So when it's thicker on the epidermis, it looks dark brown or nearly black. It's best particularly due to the accumulation on in the basal layer of the epidermis. And when it's light brown, there is less accumulation. And when it's blue, the epidermis is thickened due to what we call acanthosis. So because of acanthosis, even though you might see some melanin pigments in the epidermis, that acanthosis will allow them to look a little bit blue, especially when you see some very thick seborrheic keratosis, which are non-melanocytic lesion, but because of acanthosis, they become thickened, and then you see all this thick blue material when you're looking at dermoscopy on very dark seborrheic keratosis. We'll come back to later in something or lesions I would call melanoacanthosis or melanoacanthoma, which is like a dense dark seborrheic keratosis, which can be confusing to look like a melanoma. So hemoglobin, on the other hand, is red, but you know that it moves from bright red to blue depending on the level of oxygenation and saturation of vessels. It looks red, a dark red when you have a lot of extravasation, especially in hemorrhage. So when you see hemorrhage with blood clots and the subcorneal surface, so just underneath the skin, from trauma, it will look dark red. Even in the cuticles of the nail, when you see subcorneal or subungual hemorrhage, it will look a little bit dark red. Also, when you see blood or hemorrhage at the surface of the foot, so if you look like in what we call the black heel or talon noir, you can see that it looks a little bit dark. So I'm mentioning all these things, but we'll come to some pictures and you appreciate what I'm talking about, what hemorrhage or dark red looks like on dermoscopy. Also, hemoglobin also will look black brown when it is in the stratum corneal and the corneal surface, as I said, and also it might look red when it's fresh in the dermis. So when it's deeper, red to blue. Okay, and then sometimes it might look a little bit like green to brown due to degradation of hemoglobin. So other colors in dermoscopy, you can see a bit of orange on eroded lesions when the serum flows out of the surface, dries out and forms a crust. So you can see that, or yellow, orange yellow. You see a mixture of white to yellow, which will be found in keratin, which is as a result of keratin, with brown to melanin in terms of, so you see some pigmented seborrheic keratosis. These are the other colors that you see. Then when you see white you think of either as fibrosis or sclerosis on the dermis, denoting scarring or regression or keratin. You see creamish white in some keratin plaques in what looks like a milia-like cyst. When we come to seborrheic keratosis, I'll describe that, what it looks like on dermoscopy. So this is just appreciation of the color. So black this is the melanins will look black on the epidermis, on the conified layer around the surface. Look a little bit orangey in the middle, and then brown around the basal dermo-epidermal junction. And then it look a little bit gray if it is in deep in the dermis, or deep blue in the reticular dermis. So in the papillary dermis, it will look a little bit grayish, but then reticular dermis, it looks blue. This is the vessels, again, red in the epidermis. As you get much closer to conified layer, it's just subcorneal surface, you look red. And then you can look a little bit brownish in the deeper epidermis. Papillary dermis look a little bit blue to purplish color in deep or deep blue in a deep dermis. So it's important to appreciate it. So before I show you a dermoscopy, the history of dermoscopy it goes back in the 20s as is an inexpensive technique to help improve your diagnosis. So the dermatoscope is like another stethoscope that can be used. It used to be used in the 20s, and then in the 70s it's also known as epiluminescence microscopy or dermatoscopy, depending on who is presenting. Usually Americans usually say dermoscopy, Europeans say dermatoscopy, British say dermatoscopy. It doesn't matter, they are interchangeable terms. Austrian, German, and Italian really embrace this, and this is just, the use has spread not just from the dermatology clinic, but also in primary care to help as an other aid alongside your stethoscope, as I said. So I will show you what dermatoscope usually is in a minute. So dermatoscope uses a simple magnification of ×10 with addition of liquid on the skin surface, and then it might have polarized filters within this instrument or cross-polarized device that removes normal scattering of light on the stratum corneum. So a combination of that and that magnification and removal of the scattered light result in visualization of pigmented structures not seen with the naked eye. So that's the principle behind it. So I'm going to show you, I'm going to stop sharing now and show you a dermatoscope. What I have here is a Delta T20. I don't know if you can see there, the reflection. There is a Delta T20, a 20T, which is a honey dermoscope, and it has on it a button that you can switch between polarized. So once I switch it on, you can see the lights come on this way. And once I switch it on, I can also switch between polarized and non-polarized lights. Okay, these buttons there can switch between polarized and non-polarized lights. So that can help you in appreciating some more lesions. It can also be attached to an iPhone, and I have an iPhone adapter here where you can attach your iPhone to the dermoscopy that way and be able to take a picture of the image and when you're seeing it. So you look at it this way, and or you can attach this way where you can see the image on the phone. Okay, and if you go into your camera settings on the phone, it will show you through the dermoscopy. So that's the Honey Delta 20. This is a cheaper dermoscope, which is a Kiwi one. It's much cheaper. Also not very good in terms of sharpness of image, but it's a good starting point. It's still also a magnification of ×10. The light is not very bright, hence it's not is not that great in terms of light, but the honey ones are much more expensive, obviously. So what we have here is other types. So there's a Dem light, which is a US model. Usually it has a good advantage of ability to switch between polarized and non-polarized, like I demonstrated to you on the honey as well, and it can be used with either contact immersion fluid or without contact, and has got a good superior optics and illumination, and again it also has camera and phone connectivity. So this is the Delta honey Delta 20 that I showed you. Again, well established, robust one. You need an interface medium for contact dermoscopy, but if you're using it in a polarized mode, it does not need to be contact. I'll explain to you what those terms mean in a minute. And it can be time consuming. Obviously, you need your naked eyes to pre-select your lesion, and obviously cross-contamination is a point in all contact dermoscopy, as you touch between patients, and you also make sure your instrument is sterilized, particularly more important in these times in COVID. It can be messy if you use a contact medium there. So this is a non-contact dermoscope. So non-contact literally means you use a dermoscope to magnify the lesion, but the lesion does not touch the skin or the image, and that is a really important feature of some dermoscopy in appreciating particularly vasculature in the lesion, as if you touch most lesions with a dermoscope on a glass interface, you compress blood vessels, which don't make them really sharp. So you don't appreciate this. These are just the connectors that you can get to touch most of the dermoscopes. So just going to show you a couple of images on what dermoscopy will look like. So you have I'm going to give 4 images, where one is the naked eye, or clinical picture, and one is a dermoscopy. The 2 is a dermoscopy, but it has a non-polarized light contact dermoscopy. So non-polarized means the polarized filter is off, and you have to, because the polarized filter is off, you need to use a contact, because you cannot use non-polarized light without contact. That's the key. So polarized filter is off. However, you need a contact medium. Either being an immersion fluid, which is one of this, is the one I'm showing you in the screen. Is just a one for the honey, or you can use alcohol gel as a contact fluid. And then a polarized light contact dermoscopy is when the polarized filters are switched on when you're looking at the image. So like with a honey, I show you, you've got those buttons on the sides where you switch on for the polarized light. You can also use the polarized light as a non-contact dermoscopy when you want to look at sharper images of particularly vessels clearly, and that's another important skill to have as well. So with the naked eye, you see incident light coming in, and unfortunately, because of the surface of the stratum corneal, majority of the light is reflected out, and therefore the emitted light is not enough for you to appreciate images much deeper within the epidermis. So the light is coming in. This is the epidermis. This is the dermis, and obviously most of the lights get reflected out from the stratum corneum, and because of that, there is less remitted light coming out there, and then images or lesions in the papillary dermis or reticulary dermis are less remitted out for you to appreciate them. However, with the polarization or using immersion fluids in a non-polarized form, you want to try and remove these reflection to allowing again glare-free surface of the skin. As I explained, the polarized light, you don't need immersion fluid, and then also you don't need to, does not need to have contact with the skin if it's you're using as a non-contact form. Better for evaluating vessels, they're not contact form. And obviously, if you might have some scaly lesions on the surface, you might be able to either strip them with tape, but when you use oil, you also help remove scales on the skin. Non-polarized lights, obviously, dermoscopy always requires contact. So non-polarized light, you're always going to touch the lesion, use an immersion fluid, oil or alcohol gel, and to give you good focus. So it's still got light, but it hasn't got polarized filters in it, and that's the key. So there's not the light itself, there is a filter, so you can switch on and off the filters to cancel out their glare. So that's really the principle on it. Okay. Again, that's this is just showing you how incident light comes in, and then the reflection is remitted. Light all comes back because there's less absorption, and there's less reflection. So the remitted light is high with contact, and that's a contact medium. And then with polarized filters, again, it's the same thing. You can either use it without contact medium, it will be go here. But polarized filter switched on, then remitted lights gives you much deeper focus on lesions from dermal, epidermal junction area as well. So these are what you look in those 4 images. So this is a clinical picture of a melanistic nevus. Then B is a non-polarized contact dermoscopy. So it's a non-polarized light, but you have to touch the image to be able to see, touch the lesion to be able to see the nevus here. And C is a polarized light with contact dermoscopy, and basically it's switching on the polarized part of it, but you're touching the lesion. You can see the difference between C and D is that with polarization and non-contact, you are able to see more of redness, so the image look much more pinkish, as opposed to, if you can see in the middle of the image of the dermoscope, is much more red and pinkish, which means that the blood vessels are more prominent and not compressed as opposed to C. So those are just what it does see. Again, another similar one is a BCC here. This is a clinical image of a bit of superficial BCC, and this will be the clinical image of B is non-polarized light here, and C is polarized light. There are this kind of crystallized structures here, which is visible in BCC with polarized contact dermoscopy, but they are not visible when you compress. They are still visible here, but what you can see here, the blood vessels are not much sharper in the non-contact lesion. So if it even has a kind of nodular features to this BCC, if they've got some blood vessels or even arborizing blood vessels, they might be much more appreciated with non-contact rather than with contact dermoscopy. Okay. Right, so what I'm going to do is, again, this is another picture is of non-polarized lights, showing a bit of reflection there, and then when you use a contact medium, you lose that reflection. I talked about COVID in this day and age. Unfortunately, we're seeing less face-to-face patient, where the opportunity where you could use that time to see images, and a patient will come to you, and whilst I'm here, doc, there's another lesion here, where you can stick out your dermoscopy and look at me a lesion. It's getting less unless you've already triaged them and you really want to bring them in and you want to have a look at the images. But make sure you wear appropriate PPEs, apron, and a mask with the patient as well. and also clean the dermoscope with a surface wipe. Alcohol gel is a disinfectant, can be good use as well. And obviously sterilize in between patient. The other thing you can do is you can use a cling film in between patients for you to and change it. So you just put a cling film around the edge there, and when you're in between patients, you wipe off the cling film, and that's another way of sterilization in this COVID time. So dermoscopy is quite useful. This is a study done by Professor Genziano from Naples, Italy, and he did a study of 2,500 patients from GPs in Italy, Spain, and France, and just trying to see what dermoscopy does to help these diagnostic criteria in making melanomas, and notice that they have used 3 defined dermoscopic criteria: patients reviewed by melanoma specialists, and dermoscopy increases sensitivity by 70% versus naked eye by 54%. So naked eye missed about 23 tumors versus 6 from dermoscopy, which tells you that, really with the use of our dermatoscope, it helps us a lot to be much more accurate in our diagnosis. It's quite helpful to do that. So dermoscopy allows the observer to differentiate between melanocytic lesions, benign lesions, and malignant lesions, accuracy in diagnosis, confidence in clinical diagnosis, confirm your naked eye diagnosis, what you think it is. So when you see that something is seborrheic keratosis, you'll be able to help you to make that diagnosis. And then obviously malignant to benign biopsy ratios is quite helpful. Then you can have isolated focus within the lesion, where you can make specific suggestion based on what you see on dermoscopy, which might make you appreciate more from the pathologist, especially when you are something like when you have lesions on the face, where it might be very large and you might have one focal area which is a little bit darker. You can use a dermoscopy to appreciate what's the darkness in those areas, particularly in something like a solar lentigo, where you see a dark area in the middle. You worry about lentigo maligna or melanoma in situ. Looking with dermoscopy, you can appreciate some features on there that can help in terms of a biopsy for the histopathologist. Precise borders, you can also use this to reassure patients. It's just similar to like having a stethoscope. A patient tells you, I've got a cough, and then you listen to the chest and you say, look, I've listened, it's clear. In the same way, I've looked through the dermoscopy, I can't see any features I'm worried about, therefore I can reassure you. Using surveillance as well. Okay, so we don't want to just remove any lesions. There's so much time, it's time consuming, it's complication of surgery, scars, keloids, things like that. You don't want to overburden histopathology. And obviously, NICE guidelines recommend that we use dermoscopy to aid our diagnosis to avoid missing melanomas and removal of needless benign lesions. Accuracy will be increased by 35% if we use dermoscopy in our diagnosis. Obviously, we'll refer the suspicious lesion and less benign lesions to 2-week wait clinic. A naked eye will show you this. And these are 3 images, clinical images, where with the naked eye alone, you probably struggle to see what these are, and you might be worried, but they are all look suspicious. However, when you look at the dermoscopy of these 3 images, the first one is a nevus and regular globular pattern, and then the second one is melanoma, because you can see some blue, white, and blue purplish structures in there. A very chaotic areas. There's a bit of white areas of scarring there, and then the third one is a hemangioma, which has a regular lacunes or reddish purplish blue lacunes, which are globules or pigmented reddish blobs that you can see, which are known as lacunes. You can appreciate on dermoscopy. I will come that to hemangiomas and vascular lesions, and to see get all these terminologies, you can see what dermoscopy can help you differentiate. Okay. Other things, sometimes you can use dermoscopy in skin infestation, the scabies, and also some other non-pigmented lesions as well. And then things like in the scalp, you can use it also in some scalp disorders, and also nasal and nail fold for either to distinguish between melanocytic lesions and also if you see melanomas in the nail. And also you can see some infections in the nail, so greenish tinge in nails, sometimes pseudomonas infection. You can appreciate the greenish more in dermoscopy, and especially people who work in outside in the gardens, or gardeners who use their feet without wearing gloves, prone to get pseudomonas infection. You can show some greenish tinge in there. Subungual hematoma and pigmented mole melanoma in the nail bed as well. Okay. Again, mole mapping, it's used in dermoscopy. The ugly duckling sign is when you see a lesion clinically in a patient, which looks different by the other surrounding lesions or pigments there. You use dermoscopy to look at this ugly lesion much more closely, and then you compare to the other moles, and then you can use this, can be used in monitoring or either excision, and especially in secondary care, we use this to avoid unnecessary excision in people with atypical mole syndrome, where they have over 50 moles. You don't want to give them 50 scars, but you monitor each mole, you map them, you do dermoscopy, and if you see changes, you take out the ones which are worrying. Okay. Smartphone adapters can help you in, again, uploading all the images of dermoscopy. So this is mole mapping, and this is what is done in the hospital as well. Okay, so you have this bigger, wide area on the back. This patient has got multiple moles, and then is one that you're worried about, and you use dermoscopy to map up this image. If it's worrying and it's got features, you can cut it out. If it looks benign, you can then monitor. When you come back and you repeat and you see some changes, then it gives you confidence to take it out. Good. Okay, so we're going to take a break. This is the end of this first part. What we're going to do is I'm going to show you another video, and after that video we will after the next video will be using the standard approach in dermoscopic assessment. So you're going to appreciate that more on the next video, where I'll go to some of the principles way of making a diagnosis. So if you click on part 2 of this, then we'll start with a standard approach in looking at images.